That was a good presentation.
It was awesome.
Yeah.
Happy New Year, everybody.
Yeah, Happy New Year. Victoria, do you know if Ayana's here? Oh, yeah,
Yes, I just added Ayana to the panelist.
I see her. Hey,
Hi,
how are you?
good afternoon.
Good afternoon, Miss Mortley. Ayana Mortley. My name is Victoria Donovan. I'm a coordinator of a Bridge, Brooklyn Initiative to Develop Geriatrics Education Program. We have our faculty members here and Dr. Everton Prosper. Please introduce yourself. Maybe we can introduce ourselves briefly.
Hi, I'm Dr. Prosper, Everton Prosper. I am one of the medical doctors attending here at SUNY Downstate. I also serve as the Geriatric Medicine Fellowship Program Director, and I'm one of the co-directors on the Bridge program. Thank you.
Great to meet
Olivia?
you.
Hi, Clivia Torres. I'm the social worker on the HRSA Bridge Prep program, and I'm also the social worker on the CED team. Good seeing you again, Ayana. Welcome.
Dr. Reutemann?
Hi, I'm Jenna Rickman. I'm a faculty at LAU Long Island University Pharmacy School.
Dr. Gerard?
Hi, I'm Shirley Gerard. I'm one of the co-directors of the GWEP project and a nurse.
And we have also Sayan Kashibayo as the program evaluator today with us. Ms. Mortley, thank you for being with us. And we will be talking about elder abuse today. Just for the disclosure, this session will be video recorded, and we also have interprofessional trainees with us, medical students, PAs, pharmacy students, nursing students, residents, and dear all, today we have Ayana Mortley, and she is the workshop training coordinator for the NYC Elder Abuse Center. Welcome, Ms. Mortley.
Thanks for having me. Am I able to share my screen?
You should be able to.
Great, fantastic. Happy New Year, everyone.
Happy New Year.
New Year.
Happy New Year.
Thanks for having me. Thanks for closing out the day with me. I appreciate the time. As Victoria said, Ayana Mortley, workshop training coordinator at the New York City Elder Abuse Center at Weill Cornell Medicine. I want to thank you all just for having me again. I know that so many of us, especially medical professionals, are really focused on health and safety at this time. And so the New York City Elder Abuse Center is really trying to push to keep elder abuse education as a priority for everyone. We know that older adults and those with compromised immune systems are at the greatest risk for the virus. But unfortunately, compounding that risk, crises like these are times when you have exploiters, you have scammers that are emerging, that are coming out of the woodwork, and older adults are also at higher risk for abuse due to increased isolation or staying at home with caregivers or people who may be potential abusers and caregivers who may be overwhelmed as well. So while we're still pushing through this COVID-19 situation, we have to be vigilant about elder abuse situations that may also be occurring. And so just thank you for staying educated, for staying alert during these tough times. You're able to see my screen, is that correct? Okay, great. So the New York City Elder Abuse Center is part of the Division of Geriatrics and Palliative Medicine at Weill Cornell Medicine. Just a quick note that we really are thankful to these funders who have helped us develop and sustain programs that educate, empower, and support professionals who are identifying and tackling really complex elder abuse situations. these are the topics that we're going to try to cover today. Because I only have an hour with you and there's no way that a full elder abuse training can be provided in that time, I'll be providing more of an overview on elder abuse dynamics during our time together. I also want this to be more of a dialogue. So I welcome if people are able to unmute, to ask questions, to use the chat function as we go along to communicate any thoughts that you have, and I'll be keeping an eye on the chat. So my goal today is not to tell you all how to view the world, but just to provide you with some information that may be useful to you as you continue to navigate your work and your everyday life. I want to start by getting some feedback from you if I'm able. I just want you to give me some examples of elder abuse, neglect, or financial exploitation situations you may have seen, read about, heard on social media, read in the news, or have experienced or observed in your life, just to start us off.
Ayana?
Yeah.
Hi, this is Clivia. I know you and I had spoken about a patient that we had at the clinic once that was being financially exploited by a friend. So, so it's financial exploitation. That could be something like that. Physical.
Yep. Yeah. Financial exploitation. We're seeing a lot of situations like that, especially now in the pandemic. As I said, with these scammers are just get more and more creative and take advantage of these kind of situations. And so I'll talk about that a little bit more in a moment. Any other things that people want to share?
Hello.
Hi.
Hi, this is Dr. Emmanuel. This is one of the fellows. I had a circumstance in the clinic where I had a couple, not a couple, but an old lady. She came in with a daughter, and it was shown that that she's been diagnosed with breast cancer from, I think it's New York Presbyterian, and we're trying to pursue further workup, and the daughter was like, who told you have breast cancer? So she was like in denial. So the mom, she doesn't really speak English, but the daughter on her behalf, she was imposing her thoughts or her wishes on the mother. She was like saying that she was refusing that she has all the tests showed that she had breast cancer, but the daughter was refusing that, like, who told you have breast cancer, that they shouldn't do further workup. So I thought it was kind of weird,
Right. Yeah. So we wouldn't know if something like this is, an elder abuse situation, but you're getting to what really is at the core of a lot of elder abuse situations, which is that we're talking about families a lot of the time here. We're talking about people who are trusted and loved by the older adults, and that makes these situations really tough to disentangle. Whether whether the older adult is being influenced by their family members or they trust whatever their family member says to do, that makes these situations very challenging. And so we'll talk a little bit more about that. Any other comments to add?
We had encountered a patient where the family, certain members of the family was trying to get the patient to be declared incompetent so they would be in charge of her finances.
Yes, that is absolutely another thing. Cognitive capacity is huge in these situations. And I'll talk about that a little later, but yes, we see that a lot of the time. People who may be abusers or who may have ulterior motives are trying to discredit the older adult by indicating that they don't know what's going on, they lack capacity, such that they will be deferred to make the decisions on that person's behalf. So very common situation. You're absolutely right. And we'll talk a little bit more about that in a moment.
And two quick examples. I'm aware of a situation. Actually, one of my patients, whose caregiver nephew actually was drugging the patient, and managed to get an attorney to change all the will and everything else to his name. Anyway, it subsequently worked out that the son got involved, figured it out, and that particular person is in jail. I saw the patient many times with this individual, this nephew who was a caregiver at the time, and he was so loving and so caring that it really, caught me off guard. I did not suspect it at all. I have a second case similar. It was a home health aide who was very involved with the family, extremely loving, extremely caring. When she accompanied the patient to the physician visit, the office visits, I mean, there's no way. I mean, I was not suspicious at all. She did everything that was necessary, including physically lifting the patient out of the wheelchair, putting her on the exam table and things like that. But she was exploiting the patient, had credit cards, patient's credit cards in her name and other things, stole thousands upon thousands of dollars. Anyway, those are my two examples.
Yes, those are great examples, and we'll talk about some characteristics that some perpetrators may have, but you've gotten to really the core of it, which is that most of the time people who are harming others are going to look very charming. They appear to have that person's best interest in mind. They are very good at knowing how to play the game and to avoid suspicion. So this is why it really is important for us to stay educated and to be as vigilant as possible to identify when there might be abuse, and at least ask questions and engage the older adults themselves to get some more information. Thank you guys for those really fantastic examples. And we'll talk more about those as we go along. So just to say that elder abuse, we know, is an international problem. Victims often suffer in silence and behind closed doors, especially now with a lot of the support systems for older adults having transitioned to remote work. So while we always need more research, existing data suggests that about 1 in 10 home dwelling people 60 and older are victims of elder mistreatment in the United States. And for people who have dementia or who have cognitive incapacity, it's estimated it's about 50% of them who are victimized. So elder abuse, we know, does not discriminate on socioeconomic status, geographic status, religion, or any other status, and yet it is so often hidden. There's elder justice experts who say that elder abuse today is where intimate partner violence was 40 years ago. Like when it was hushed, it was considered a private matter, not my place to intervene. When you call, you might call the police and the police will say to the person, okay, take a walk around the block and cool off. And there wasn't really intervention, but we're still working to continue to make elder abuse to raise awareness about elder abuse and to work more closely with each other on elder abuse cases to identify and intervene. So despite that, we continue to push through in elder justice work. And on the other end, there are medical researchers who say that elder abuse is the most common condition of older age that's largely preventable, unlike a lot of the diseases and conditions associated with older age. So that is a sobering statement. And so we recognize elder abuse as a human rights issue. Just by virtue of being human, we have the right to be respected, to be treated with dignity, and free from harm and free from the risk of harm. So these are the types of elder abuse. Through your examples, you've already covered a lot of these already. In New York State, financial exploitation is the most commonly reported form of elder abuse. And yet, despite that, 1 in 44 financial exploitation cases actually come to the attention of law enforcement, victim services, adult protective services, or another entity who can respond to the situation and protect the older adult. For all forms of abuse, that number is 1 in 24 cases that get reported. So elder abuse continues to be really a silent epidemic, and more so we know during the pandemic, with mandated physical isolation, with the loss of many jobs, with religious services and senior centers that have been shuttered. And although many of us are really still fighting to keep older adults connected, that is a priority. One thing to note is that these types of abuse co-occur. So if an older adult's money is being taken by their daughter, for example, there are quite possibly also threats to hurt that older adult or hurt the older adult's loved one or their pet. There's quite also possibly manipulation or humiliation or denigration or worse. So if there's red flags for a type of abuse, it's important that we are being vigilant and screening for other types of abuse. People who work in domestic violence may be familiar with this wheel, this power and control wheel. It's an instrumental tool in the domestic violence field that was developed in the early 80s. This actual wheel that you're looking at has been adapted by the National Clearinghouse on Abuse in Later Life. for abuse in later life, for elder abuse. In elder abuse cases, sometimes we can assume that elder abuse is a result of strained family dynamics or caregiver stress, but we have to look for power and control dynamics in these cases, since they can absolutely be the cause of elder abuse, intentional neglect, and financial exploitation. Power and control can really be central in some of these cases, and so this wheel provides us a guide for how to assess power and control dynamics in elder abuse situations. On the outer rim of this wheel, we see physical and sexual violence that perhaps, or so it appears, manifest less frequently, but it's the ongoing threat of that physical and potentially sexual violence that is used to maintain victim compliance. The wheel illustrates the variety of tactics that abusers use to gain and maintain power and control over the older adult. So the spokes of the wheel show the behaviors that are happening most of the time. So perpetrators often use a victim's vulnerabilities to maintain that control. They may take the person's walker and place it where they can see it, but not where they can reach it. They may refuse to drive the older person to their synagogue, to their religious services. They may destroy the person's Bible. They may threaten not to let the person see their grandchildren or to hurt someone, a pet that they love. And so these methods can systematically make it more and more difficult for a victim to reach out for help to the systems that can provide services and can protect them. So to visualize what an elder abuse case can look like, I want to take a moment and share this video.
Hello, son. Did you get my medicine?
Damn it, Mom. Just got back from work. Give me a minute to unwind, will you? Jeez.
I'm sorry. How was work?
How do you think it was? Nothing ever works out for me. It sucks. You got this pile of pills in front of you. You know how much those cost? What do you need a new one for, really?
But Michael, the doctor said that I need that new pill.
What do you know? You don't remember shit anymore. You know, if you don't like the way I'm helping, if you don't like the way I'm taking care of you, I'm going to put you in one of those homes. Think about that. That'll give some. Think about living in one of those places. I'll take you over to one of those places.
Oh no, Michael, please, don't say that. I'm sorry. I'll be okay. You're right. I've got all these pills. I can wait. Are you going to go to work today, Michael?
Work? Where do you think I've been all day? You are so clueless. I got to get out of here.
Michael, I'm sorry. I'll be good. I'm sorry, Michael. I'm sorry. I'm sorry.
So this is a reenactment, and I've seen this video many, many times, and every time I see it, it is very hard to watch. The video is designed to illustrate what happens behind so many closed doors. More than half of elder abuse situations involve family members, trusted contacts of older adults. So we're talking sons, daughters, spouses, grandchildren. And that's one of the reasons that these cases can be really tough to identify and address. So I want to take a moment and just debrief from what we saw in this video. And so please feel free to unmute yourselves. I want some feedback from you. Is this woman being mistreated? Why or why not?
You want us to think about it, or you want us to chime in?
I want you to chime in, please.
Yes, she's being abused emotionally. Absolutely.
What did you, go ahead.
He's also not giving her the medication that she needs. Right.
Right.
No. Taking care, probably controlling her money financially, maybe.
Mm-hmm.
You know, psychologically, he's really messed with her head.
Yeah, what did he say? You don't know anything anymore, right? Yep.
And not only emotional, I mean, you know, it kind of borders on physical. I mean, he didn't physically touch her, but he's in her face, right? I mean, he's
I
literally,
agree with you. Yeah.
yeah, he's like right there, and that could
Yeah.
be so terrifying, so intimidating. To some degree, she may be frail. I don't know what else is going on with her in terms of her history, but he's literally towering over her, so
Right.
imposing. So yeah, it's a
I can I just jump in on what Dr. Prosper said? I wanted to say also physical as well, because I felt the same thing that you did. He's not necessarily laying hands on her, but there was that sort of well, I mean, just her response signaled that she perceived that suggestion as a threat. And you're absolutely right in terms of the body language that it's not a conventional, maybe physical threat, but I agree with you. I think that there's something very sort of physically threatening. I have the capability of doing whatever I want to you.
And keep in mind, we're only seeing this one event at this one point in time. The first thing that he did when he walks through the door is open up a can of beer, right? And if you look in the background, you see quite a number of other beer cans are there in the background that are clearly empty. So we don't know what happens the next time he drinks and he comes home and he's frustrated. He may physically strike her. We didn't see it at this particular point in time, but we don't know what has happened in the past. To your point, Everton, about her potential vulnerabilities, yeah, she's sitting there in a wheelchair. We don't have enough information about how well she can take care of herself. Can she transfer out of the wheelchair? Can she toilet herself? We don't know how long she's been sitting there waiting for him to come home. Are there any other supports? Perhaps she's been sitting in that chair all day and she hasn't eaten, waiting for him to come home. And they get into this argument and then he just gets up and walks out and leaves her there again.
Yeah, and I want to add one. I would like if some of the other participants want to comment. I would appreciate it. I don't want to monopolize the comments, but just one other thing that came to me, and I dislike this kind of thing, just elderly abuse. He left, and I get the impression as if she's apologizing because she is wrong, and so that's how manipulative this kind of environment is. She depends on him heavily, right? And he's twisted it in such a way that she's apologizing for what he's doing, and that's a problem.
And also I'll just add that he creates a very unconducive environment for her to live. So she kind of like box her in a corner, and she'll be like very scared to actually be free in that house, like to do things freely.
Yeah, it absolutely seems like she may be isolated here. And to the point of the power and control dynamics that we were talking about, he's threatening her. He's threatening to put her in a nursing home, which we know as professionals, that's a very scary threat for an older adult. Many older adults we know, they don't even want to go to a hospital. They're afraid that if they leave their home, they will not make it back home. So that's a very serious threat for a lot of older adults and can absolutely be used to obtain compliance.
It's a hostile environment for her.
Yes, and to the point that was just made about her apologizing for the way that she is being treated, for him refusing to fill her medications, for him walking out on her, for him drinking, for him threatening her. She's apologizing. So it's a very emotional event for these people, and you can imagine that this man is probably her only support system. Of course, she doesn't want to lose him. Of course, she wants to please him. She doesn't want to make him upset, so she's blaming herself. Anything else?
I think it goes even deeper because he's not just some caregiver that she needs to appease. He's her son, so she has an inborn desire to care for him and for him to want to love her back. So it's really a next level of abuse because
Absolutely.
she's always going to be positive toward him.
Yes, and this is something we encounter in so many cases. So we touched on just some of the things, and there's a lot more details to be noticed in this video about how complex the situation is, just based on this one scene that we see. But we like to say that elder abuse is more than just the broken bone. So often when we ask people, like, what are the types of abuse? Talk to us about what abuse looks like. The first image that comes to mind, you are a very sophisticated audience, so we didn't get this answer from you, but the first image that often comes to mind is, you know, the black eye, the broken arm, it's physical abuse. But as we see in the video, it's so much more than that. It is that psychological and emotional abuse, threatening to put her in a nursing home. It is that abandonment, just getting up and walking away when he's upset, when he's frustrated. It is that neglect, refusing to fill her medications. We don't know what those medications are. What if one of those medications is a seizure medication and she's not getting it because of because of him? And it is a financial exploitation. Perhaps she does rely on him to manage the finances. What if it's her debit card that he's using to buy all the beer cans and the beer bottles that we see in the background there? What if he's not getting her enough food? So there's unknowns in this video, but this video is just designed to illustrate what a lot of these elder abuse cases look like. They are complex. This man, her son, is frustrated with work, as we heard him say, so he likely needs some support there too. And so who alone can disentangle all of these parts? We say that these cases require a multidisciplinary response, and no one professional would be able to address all of the things that we see in these cases. It requires collaboration. So this is a definition that we use at the New York City Elder Abuse Center of elder abuse. We're talking about a single or repeated act or lack of appropriate action. So again, that refusing to fill that medication can result in harm to her, causing harm, risk of harm, or distress. We work with people 60 and older, and we're talking about relationships where there's an expectation of trust, those family members, the loved ones, the trusted contacts, intimate partner, family relationships, or when the person is targeted because they are an older adult or because of their ability status. It's the cases of the day in, the day out, humiliation, manipulation, shame, and fear that are really, really tough to tackle. So those are the cases that we're working on. So I want to hear feedback from you again. We've already kind of talked about some of these factors. So what are the things that make these cases so complex?
Cultural, just cultural complexity. What culture is this person coming from?
Fantastic. Go ahead.
And different family dynamics operate differently in different cultures.
Fantastic point that hasn't come up yet, but it's something that is a larger and larger part of our dialogue. To the best of our ability to be culturally responsive is what we want to do. I mean, we have studies that show that every group thinks of abuse differently, and there's many groups who if you say, hey, your son took this amount of money from you, this might be financial exploitation, and that person may say, no, my job as a parent is to make sure that my son has whatever financial thing he needs. So are you telling me that I'm not doing my job or this is exploitation? I disagree. So yeah, fantastic point on cultural norms. Anything else? We've been saying over and over again that the abusers are often, the trusted contacts, the loved ones, family members. Anything else?
Can I say something about cultural?
Sure.
Yeah, this is a pediatric case where a father was disciplining. He was from Africa, I don't remember which country, and he was disciplining his son here in the United States, and he broke an arm doing it. And he said, well, in my culture, I'm allowed to do that. The answer to that was, well, you're in the United States and you're not allowed to do that. Then the subsequent follow-up that occurred was that people emailed in and said that even in his culture, that degree of discipline was not acceptable.
Mm-hmm.
He used the cultural excuse to say that he was allowed to discipline his child. In this case, it was a child, to the extent that I can't remember whether he broke an arm or a leg, but he broke something. And of course, that was unacceptable, but he used the cultural excuse to say that it was. And in fact, even in his culture, it was not acceptable.
Right. Thank you for, yeah.
Oh, I'm sorry. Is it Dr. Mortley?
This is Dr. Harris.
Oh, no, I was interrupting our presenter. I was also going to chime in with the gentleman who just spoke before me that, so I am a medical anthropologist, and I did my research internationally and did, ethnography. And, there are absolutely these sort of moments where we're kind of conflicted about, it's like the prime directive in Star Trek, like our role is not to basically go there and to tell people how they should live their lives according to our Western values. Having said that, I just wanted to also share with Dr. Harris, I guess, that the one area that I had a similar experience, although this was not elder abuse, this was just intimate partner violence, that I was living with a family, and the father basically was beating up his wife, and I came into the kitchen and he was about to kick his wife in the face, and the baby, who happened to have been named after me, was on her back. And I just, at that particular moment, decided, I don't care. I'm going to be that American. And I basically kicked him out of the house and sort of said, I don't care. I know this is Zimbabwe, but this house is going to be America. I mean, like, I'm not going to sit back. And I share that with you because it is sometimes really tricky to figure out when we are working internationally. However, these experiences are happening here within the United States. So blaming it on sort of, culture, the one thing that is to our advantage is the fact of our context and the fact that we have laws, et cetera, to regulate sort of what is considered abuse or not. Nonetheless, I'm sure that people will want to throw in, but this is our cultural practice. And it was really, I really struggled with that particular moment and writing to my advisors about sort of, being ethnocentric and sort of imposing sort of my particular will on this moment. But it was, but I wanted to chime in that it depends on our context, and we're in a different context. And so we can use that as leverage to be able to say, I don't mean to be disrespectful about your cultural beliefs or practices, but here in the United States, you can't beat women. You can't beat elders.
Thank you for that. Thank you for sharing that experience with us, and thank you for that comment. It's extremely important. And yes, this is why for these situations, we really try to take them on a case-by-case basis. We really try to honor the self-determination and autonomy of the individual, of the older adult, and make sure the conversation is about their safety. I don't know, it's impossible for us as professionals to know what all of the cultural norms are for the people that we work with. But at the end of the day, if we're talking about this person's safety, and we're ensuring that we are honoring what that person's wishes are to protect themselves and keep themselves safe, we may be able to sleep a little more soundly at night.
And I don't know, Dr. Taylor, and maybe you can help me. Sorry, but I don't know the right words, but there are times when we need to say that, it might be a culture, it might be a cultural norm, but it's not right. I don't know if we can be so direct or so blatant to come out and say it in certain contexts, but sometimes we do need to say it.
Well, I think that's the problem with pluralism. Like, we live in a pluralistic society in America where we're supposed to accept everyone's beliefs until they start impacting other people's beliefs, infringing on the rights of other people.
I disagree. That's not what being in a pluralistic. I mean, we need to be respectful of different views, but there is a definitive line that is
right, and that line was based
by the
on
law.
But you drew that line based on your ethnocentrism, which you admitted, right? So
no,
you believe.
No, yes, that was in Zimbabwe, but here, like, I'm a mandated, a court responder. If I hear, someone threatening, wanting to do harm to themselves or to someone else, I have to report that. And so there are laws, and I guess what I'm trying to say is sort of within this context around the fuzziness of, am I going to be disrespectful about someone's cultural beliefs and practices? I think what we need to do is we need to stick to the laws. We need to understand how we can justify. And what I'm trying to sort of say is around abuse, and I don't know if this is done within the curriculum in terms of training or in med school, to really be able to understand sort of what are the laws around abuse. I think that so many people who are coming from other countries are not necessarily fluent with our legal system and with the language. And so I think that sort of this is one of those moments where doctors can really do something in terms of understanding the laws. I think it's most pronounced around issues of abuse and intimate partner violence and child abuse, of course.
Thank you guys for this. This is actually this is a really important dialogue, and I'm keeping an eye on the time. I think it would absolutely be worth it to continue this dialogue if you all can make time for it. And whatever resources I can share to your points, I absolutely will do so after we finish talking. So I just want to make sure I just want to make sure that I can provide you with information that is useful to you, and absolutely a follow-up dialogue should take place. You guys are talking about very important information, concepts for doing your work and knowing that you're doing your work well. So I might skip some of this stuff, but I'll just quickly go through some of it. So yeah, so we talked about a lot of these already, why these cases are complex. You know, there's, as we saw in the video, there's fear, there's shame that influence the decisions that older adults are making about how to protect themselves and what interventions they will accept. Of course, we know cognitive capacity, isolation play a huge role as risk factors and affecting decision making and access to services. And then we see substance abuse in both, you know, the older adults sometimes and the people that are harming them, and that makes these cases far more complex. As we know, we absolutely do not have enough resources to address substance misuse. And so what does this matter? Of course, we know that, you know, we all deserve to be treated with dignity, but the harms of elder abuse are tangible and the costs are great. So these are just some of the consequences of elder abuse. Elder abuse, we know, triples the risk of premature death. It causes, we know, unnecessary injury, illness, and suffering. Victims of elder abuse are 4 times more likely to be admitted to a nursing home and 3 times more likely to be hospitalized. So you all may be encountering the victims in your work, perhaps at least one every day, really, if you screen properly. When it comes to financial exploitation, economic losses are huge, not just for older adults, but for families, for businesses, for government programs. You know, financial exploitation increases the reliance on Medicaid, for example, and research indicates that people who have cognitive incapacity suffer double the amount of economic losses as people who don't have cognitive incapacities. When it comes to, there's a study of older women that finds that when it comes to just verbal abuse only leads to greater declines in mental health than physical abuse only. And so with all of these factors, elder abuse absolutely causes victims to be more dependent on other supports to help with their care. And we know as a result of providing care, there are times when those caregivers can experience declines in their own physical and mental health and perhaps their own financial security. And again, we can think about how all of that is compounded by COVID-19 pandemic. So elder abuse prevention could absolutely save lives, prevent injury and suffering, and diminish the economic losses of abuse. So let's talk quickly about some risk factors. I'm sure that you already may know this, so I'm going to just speed through it. We know that elder abuse does affect older adults across all demographics, but these are some particular risk factors that emerge from the research. For the older adult, just look at the top 2 on the left side: shared living environment and social isolation. These are, of course, particularly a concern during COVID-19. We know that we are receiving more and more reports from professionals that a lot of their clients are staying at home with family members, and those family members have the potential to or are harming them. And it's very difficult for us to engage and intervene in those situations when they're in the room with or just next door to the person who may be harming them. So those are a particular concern at this time. And social isolation, just to make a note that we often, because of our cultural ageist attitudes, we often overlook isolation and overlook the fact that it is used as a tactic by abusers to gain access to the victim and ensure that the victim cannot get the assistance that they need to keep them safe. So we have to check our assumptions that just because a person is older, they would naturally be more isolated. They would not want to attend their now virtual senior center. They would not, that they would lose interest in things or be more depressed in order to identify when isolation is occurring intentionally. For abusers, we kind of see two profiles that tend to emerge in many of these situations, where abusers may have untreated mental health conditions, and that can be combined with substance misuse. And then when there's a history of violence, then some people refer to that as like a powder keg for a potential abusive situation. And yet we also do see caregivers who are depressed, who have anxiety, who may be resentful towards the older adult. Before I did this work, I worked for Adult Protective Services for a number of years, and there's always a case that stood out in my mind that came to me very early on in my time as an Adult Protective Services case manager. And it was a situation where it was an older woman who had recently suffered a stroke, and so she was in a wheelchair, and her daughter was acting as her caretaker. But when I met the daughter, it was clear that the daughter was frustrated, and what I was beginning to hear from her was resentment. So she was saying, I have siblings, I have brothers and sisters, and my brothers and sisters they have their families, they're living their lives, and yet it's falling on me to take care of mom. And why is it falling on just me? Why can't they help? And so I was hearing what seemed to be resentment. And so these are situations to listen out for, because these are situations that can result in neglect, can result in harm towards the older adult. Although, as we discussed at the very beginning of our dialogue, abusers come in many forms and have many different motives and often appear quite charming. So these are some protective factors that absolutely can be implemented by medical institutions and by medical professionals. As many sets of eyes and ears on these situations is always a benefit to being able to identify elder abuse and intervene in elder abuse situations. Support systems right now, medical professionals are huge supports for older adults who many of them have lost or have more limited contact with their typical support systems, but they are still managing their medical needs. They're still managing their financial needs. So these are the folks who we're seeing are really now at the forefront of being able to identify elder abuse situations. And those support systems are extremely important because you guys are the folks who can report it. Screenings, effective policies and procedures on patient and client care. Screenings we know are extremely important. Does downstate have elder abuse screenings? Does anybody know?
Are you talking about inpatient or outpatient?
Yes. I know for outpatient, some clinics do.
Okay.
But the inpatient's required by the Joint Commission. And if any of the outpatient clinics are part of the HCUPs and the other data, they would be screened then as well.
Great, fantastic. Yes, we're always trying to rally folks around developing and improving elder abuse screenings. And emergency rooms are a particular place where sometimes full screenings are not done, but absolutely can be done when radiologists work together with social workers, with physicians to really uncover what could be a picture indicating potential abuse. Just a note on holding the abuser accountable. Sometimes the matter is caregiver stress, as we discussed, and especially in the pandemic, as we discussed. So programs to support caregivers, there's never enough of them, but they are extremely important. And sometimes the situation is power and control, as we discussed. And so we do work to hold the abuser accountable for that. We do sometimes involve law enforcement. Sometimes sometimes if the older adult wants, we work to have the abuser who may be residing with an older adult to be evicted from their home. And sometimes that abuser is hospitalized if there are untreated conditions and they're putting someone at risk of harm in order to protect the older adult. Sometimes they are hospitalized as well. So we do hold the abuser accountable. So I'm keeping an eye on the time. I do not want to keep anyone longer than needed. So I'm going to skip this section. I will send you all these slides after we talk. So, and these are red flags, which I'm sure that you know. We kind of conceptualize them as falling into these three categories, but the medical history can give you a lot of information. I know that you may see situations where the person has frequently hospitalized or is referred to as accident prone, or you may not see when people are doing doctor hopping, ensuring that the older adult or that the victim does not go to the same hospital more than once, so no one can get a full picture of what is occurring. And the physical, the affect of the person is a huge red flag that professionals can sometimes catch. And those interactions, so those situations where you're seeing, to Everton's examples that he provided about meeting the home attendant in the presence of the patient and not having suspected anything because these people are often so charming. Sometimes interactions, if you listen closely, you can pick up on something that can be red flags. I can speak from my own experience that I absolutely have heard situations where the older adult have encountered situations the older adult would just defer to the trusted contact, would just say, don't ask me, ask my son, don't ask me, ask them. Or if I'm communicating with someone over the phone or remotely in some way, I'm not sure if you all are doing telemedicine at this point, hearing people being coached in the background, people in the background coaching the older person. And just those little nuances of communication between the older adult and the trusted other can give a sense of whether there might be harm occurring. Financial exploitation, you may find out about when it comes to the person's benefits. I'm not sure to what degree details you might find out, but important to keep in mind, just given what we know about the amount of scams that have emerged in COVID-19 and that are always emerging throughout the year. Sometimes.
Could I add one thing that's
Yeah.
very specific about New York, Milo Sapa?
Sure.
Which is New York has this law or something that sort of, if someone is in your house, like if a house guest stays in your house for more than a month, that like they can't be simply evicted. And so there was an elder abuse case in my clinic where that was the case. And this son kind of got out of jail and came home and they could never get him out. And this poor older woman was basically being terrorized. And so I don't know what could be done around that in terms of seeing these flags early, in terms of, also asking, do you have guests, guests who've kind of overstayed their visit? Because that's also something that there's this loophole there that really puts older adults, it makes them vulnerable.
Yes, you're absolutely right. You're talking about squatters' rights, essentially, and we see that in a lot of cases. To the best of our ability, if we do find out that there is someone who is in jail, we do our best to find out when they're getting out so preventative measures can be taken. Legal aid does have programs, and some of the other organizations do have programs. The local elder abuse prevention programs do have advocates that can assist the person in going to court to have the person formally evicted from the premises if they've stayed longer than if they are essentially a squatter. So there are resources for that, and we see those situations very, very common, honestly. So thanks for bringing up that great point. So I'm looking at the time. Elder abuse and COVID-19, I will send you all an article that talks about this in depth and how COVID-19 has specifically affected elder mistreatment, what we've seen in New York City. So I can send that to you after. We've already discussed why it's really challenging for older adults to be able to talk about mistreatment because of shame, because of fear of retaliation, because of that guilt, that self-blame that we've discussed. These are questions that I imagine in your screenings, some form of these questions already exists, right? And so I know that you all know how to go about administering these screenings, universalizing, trying to get to these things in a conversation. That first word rapport is very important. People have told me that when they look at this slide, it's clear that the first word in the title, rapport, is extremely important to being able to get an accurate, an accurate response or a sufficient response to any of these questions. There are resources for people who do have cognitive impairments who may be victims of elder abuse.
Ayana, can you just say you don't lead with that question? Okay, so you have to build a rapport before you get to those questions.
Absolutely, that's what I was saying.
Questions, you start off and you build trust, then you get to those questions.
You're absolutely correct. The order of the words is extremely important. Rapport is extremely important before you can even ask the questions. And yeah, I would like to hear from you. Well, yeah, you're absolutely right. Thank you for making that point. There are resources for people who may have cognitive impairments and cannot explain what happened to them. We do work collaboratively with Adult Protective Services who can perform psychiatric evaluations, who can perform some involuntary services to stop financial exploitation, for example. I know that in the hospitals, capacity assessments are done. And of course, as a very, very last resort, guardianship. But even guardianship is not a magic wand, as we know. And so just as a quick talk on some resources, first, well, I'd like to hear from you all. If you encounter what appears to be an elder abuse situation, what do you guys currently do?
In the clinic?
Yeah.
So, okay, so since 18 and I are both the social workers and we generally are part of the meetings with the patient, if we suspect it, we initiate a report to APS. It has been very challenging for us sometimes to get them to accept cases. I'm gonna keep it real. It has been extremely difficult for us to have them accept some of our referrals because they say that if there's a family member there, that there's no proof and so on and so on. However, we do have concerns, so we will continue calling the case in.
And we also, as far as I know, I mean, since the pandemic, the cases that we refer, it's been hard for us to be in contact. At least I have not received any calls regarding the cases that I refer. I usually provide them with my personal number as well because we still working remotely. So I give them my personal number. So if they need to get more information from us, we can touch base. But yeah, I know probably this pandemic's been hard, but yes, it's challenging.
Okay.
Get a hold of them.
Completely understood. Yeah, so we're fortunate in New York City that we do have a number of agencies that can respond to abuse. For most professionals, the first call they make is Adult Protective Services, but as you said, Clivia, a lot of the time people are not satisfied with the outcome, or they don't understand why APS made the determination that it made. So APS is the place to refer when you do have a person who is 18 or older, who has an impairment, who does not have anyone who's able or willing to assist, and who is at risk of harm. The Department of Aging, if you just call, what I would say is the bottom line is it may make more sense to call 311. I know it's kind of strange to call 311, but at the end of the day, based on the information that you give them, they will filter the referral to where it needs to go. So there's certain keywords that they know means that this should go to APS or to go to the Department for the Aging for a variety of other services that they provide. The New York City Elder Abuse Center can also help with that. We provide case consultations. So if you have identified what could potentially be abuse, you want some thoughts on what exactly you're looking at here, what the best next steps can be, you can call us, you can email us, and we'll help identify what the best next step should be, what the best organization might be to connect to. And we are essentially a partnership of over 30 organizations in New York City, so we can connect directly to who the appropriate agency might be to address this situation. We've been
Yeah,
getting, yeah.
I'm sorry, Ethan and I actually had a patient that we had extreme concerns because at the time of the appointment, the caregiver told the patient, you have to give me the $25,000 you promised me. So I remember Ethan and I called APS, and APS really didn't want to accept the case, but we did get help from other agencies, and they were, I mean, the DA was involved and so on and so on. It was just difficult for us to get feedback as to what was happening, but I agree with you. There are other agencies, and you just have to be persistent and call it in.
Right. Yeah. So, and if you're not sure which agency to call, you can call NICEAC. We will give you some guidance on that. And to my point before, it absolutely requires a multidisciplinary response. So for that case, yeah, the DA maybe had to be involved. There may have to have been some other agencies that are involved to make sure that all the person's needs can be met. So it's 5 o'clock. Oops, I'm going to skip through this. This is just and I'll send you all this afterwards and some more information. The bottom line for us is just that, these cases are extremely complex. As you know, there is no one size fits all. We do our best to honor the self-determination of the patient. And we absolutely have to collaborate in order to ensure that the person can be safe, can be kept safe and protected from harm.
Excuse me.
I will send you, I'll send you all this information afterwards because I see it's 5 o'clock. Any last thoughts, any last comments? Thank you all for your time. Thank you all for being so engaged and for offering really important comments that, in fact, I will try to infuse into this workshop the next time.
Thank you.
Thank you.
Thank you, Mortley. That was wonderful.
Thank you. Thank you very much.
Thank you.
Oh, okay.